Good morning, both.
Recording in progress.
Why is it echoing?
Yeah, brother, can you
Morning, everyone. Is my screen visible and am I audible? Should I wait, sir? Am I audible? Am I audible? Am I audible? Yeah. Shall I start, sir? Morning.
Yeah, good morning. You can start, Brian.
Yes. So, morning, everyone. So, today I'll be speaking about the surgical anatomy of ACL. So, as you all know, the anti-cruciate ligament is the primary restraint for anterior translation of the knee in flexion, and also in addition to that, also acts as a secondary restraint for valgus and valgus strains in the knees and extension. Though the direct implication of ACL tears and direct progression of osteoarthritis is debated, there are many studies convincingly showing the integrity of ACL is crucial to prevent ongoing meniscal tears and thereby leading to osteoarthritis. So, goal in the treatment of ACL tears would be to as close as possible, accurately reconstruct the anatomical locations of ACL to restore normal kinematics within the knee. So, just briefly about the history of ACL. There have been descriptions of ACL as early as in the 3000 BCs, and for long period of time, it is considered a single homogeneous structure arising from the femur and attaching to the tibia. The two bundle concept was introduced as early as 1836 by Weber, based on the insertions in the tibia, based on the tibial insertion sites as the anteromedial and the posterolateral bundle. However, it again started gaining relevance only since the late 80s. In addition to the two bundle concept, there has also been a three bundle concept introduced by Narwood and Cross et al. In 1979, where they describe the presence of additional intermediate bundle in addition to the AM and the PL bundle. So this was the description provided by them, where there was an anterior bundle, intermediate bundle, and PL bundle based on the femoral sites. So what they proposed was that the anterior medial bundle was contributed to anterolateral stability of the knee, and the intermediate bundle has contributed to the direct anterior stability and anteromedial stability, and the posterolateral bundle was assistive in posterolateral stability of the knee. However, further studies have disproven and have shown that the intermediate bundle was indeed a part of the anteromedial bundle. So this concept is no longer valid, and currently only two bundle concept is accepted. Apart from this bundle concept, there is currently a ribbon concept describing that the bundles seen in the ACL may be functional rather than anatomical. So, briefly about the embryology, it can be seen as early as the 8th week of gestation, 8th week of the fetus. And it is formed by ventral condensation of blastocystis within the knee. With the formation of the knee joint and formation of distal femoral condyles, this condensation migrates further into the notch. And point to note is that the menisci also has a origin from the same tissue. So thus explaining interdependent function, the very close proximity of attachments of the ACL and the meniscal origins. Bundles can be, the distinction between anteromedial and the posterolateral bundle can be seen as early as the 16th week. So as can be seen here, there is a minute septum dividing the bundles in anteromedial and posterolateral bundles. So quickly about the neural anatomy of ACL. It is applied by the posterior articular branch of the tibial nerve. The ACL is filled with numerous mechanoreceptors, each specific functions. So there are Ruffini's receptors, which are predominantly involved in detecting stretch of the ligament, and predominantly found in the femoral attachments. The beta Pacini receptors are detect rapid movements, and they are seen in both the femoral as well as the tibial attachments. The normal Golgi receptors are seen spread out throughout the entire length of the ligament. And in addition to these stretch receptors, there are free nerve endings, which are the primarily pain receptors within the ACL. In addition to being pain receptors, they also aid in releasing vasoactive peptides, which is thought to regulate long-term graft remodeling. So what is the relevance of these mechanoreceptors? It has been shown that these mechanoreceptors are not primarily involved in, they involved in something called ACL reflex, which is not primarily protective reflex for the knee. Rather than that, it is regular feedback which causes recruitment of muscle spindle fibers, thus enhancing quadriceps function. So this was a study published by Konishi et al. In 2002 in Journal of Medical Sciences Sports Exercises, where they have followed up patients with the ACL intact and ACL deficient knee, and found that the patients with the ACL deficient knee had significantly less quadriceps spar compared to ACL intact knees. So the theory put forward by them is that there is continuous stimulation of the motor neurons by receptors within the ACL skin and the capsule, which is important for activation of muscle spindles and thus activation of high tension motor units. This was what ultimately resulted in the adequate quadriceps power. So these are receptors independent from the low threshold motor units, which are recruited anyway. So in patients and an ACL deficient patient, this reflex arc is inhibited, as seen in the dotted line, meaning there's not enough recruitment happening. Thus, they are supposed to have weak quadriceps power. So the advantage of preserving ACL remnants is twofold. One, primarily to improve proprioception of the joint, and other than that, it is required for long-term adequate quadriceps power in the patient. Quickly about the vascular anatomy, main blood supplies from the middle genicular artery. As you can see, is a branch of the popliteal artery, descends vertically and then goes into the notch and supplies the primarily femoral attachment of the joint. These vessels form a periligamentous network and present throughout the upper half of the ACL. The distal part receives blood supply from the inferior genicular artery. And as you can see, the blood supply is non-uniform. There is a very predominant avascular area of ACL seen 5 to 10 mm from the attachment of the tibial side, thus explaining the poor healing capacity of ACL. This is again a cadaveric specimen with the dye injected, showing the vascularity of the ACL at the femoral attachment and the vascularity of ACL at the tibial attachment, and a very large avascular zone in the mid-substance. So coming to the microscopic anatomy, as you know, the ACL, though intra-articular, is extrasynovial structure. It is enveloped by 2 synovial layers. So here's a cadaveric specimen showing the synovial sheath covering the ACL. And it is predominantly consists of collagen, type 1 collagen over type 3 collagen. And there is a septum dividing the ACL into an anteromedial and posterolateral bundle. So septum is consisted of vascular derived stem cells, which as shown by the study in Matsumoto et al. In 2012, these stem cells seem to have a important role in regulating ligament or tendon to bone healing, and thus could be crucial in graft remodeling, graft integration after injury. Yeah, and looking at the microscopic insertion of the ACL, so insertion is 4-layered, in from the ligament to a layer of uncalcified cartilage to a calcified cartilage and then onto the bone. The significance of this 4-layered insertion is that it prevents the direct stresses at the insertion size and dissipates the force transmitter along the ligament. So coming to the macroscopic anatomy, as you know, the ligament ACL originates from the lateral femoral condyle, takes a oblique course within the knee from a lateral posterior to anteromedial direction and inserts into the central tibial plateau between the tibial spines. The intra-articular length of ACL is roughly 32 millimeter, and it has an hourglass appearance, meaning it is wider at the base and the origin rather than the mid substance. Yeah, as seen by fanning, because of fanning of the insertion sites. So the mid substance and the cross section area of the mid substance is about 40 millimeter square, where the insertion is threefold. So here you can see the mid substance of the ACL, and there is fanning and attachment of the femoral as well as the tibial sites. So as discussed, it is composed of 2 bundles based on the insertion in the tibia. There's the anteromedial and the posterolateral bundle separated by a spine septum. Since the anteromedial bundle has a definitely longer trajectory, it is nearly twice as long as the posterolateral bundle, but both bundles seem to have a similar cross-sectional area at mid-substance level. So coming to the anatomy of footprints at the femur, the femoral footprint is predominantly crescentric, but can have a variable shape. So the dimensions would be 18 millimeter in cephalocaudal direction and 11 millimeter in anteroposterior direction. The important bony landmarks concerned with the femoral footprints would be the lateral intercondylar ridge, also known as the residence ridge, and the lateral bifurcate ridge, which runs perpendicular to the lateral intercondylar ridge. The bifurcate ridge is the important landmark for locating the center of anteromedial bundle and the posterolateral bundle in the femoral footprint. So naturally the anteromedial bundle is proximal to the lateral bifurcate ridge, and the posterolateral bundle is distal to the lateral bifurcate ridge. So coming to the anatomy at the tibial level, so just like the femoral footprint, this also has a broad area of insertion seen between the medial and the lateral tibial spines. And it also has a varied shape from an elliptical to triangular and even a C shape. So it is about 17 mm in the anteroposterior direction and 11 mm in the mediolateral direction. As described, the bundles are described based on the location. The tibia as the anteromedial, which is much larger, and the posterolateral bundle. The tibial insertion is nearly 1.2 times as much as the femoral insertion. So another point to note with relevant to the tibial anatomy is that it is in close proximity to the lateral meniscus. The posterior, both the anteromedial and the posterolateral bundles are very close proximity to anterior horn of the lateral meniscus, and the posterolateral bundle, in addition, is just anterior to the posterior horn of the lateral meniscus, and the anteromedial bundle is very close proximity to anterior horn. So important clinical relevance of this is that the anterior horn of the lateral meniscus used as surgical landmark for locating the center of the ACL footprint. So coming to the functional anatomy, as the AM bundle is lax when the knee is in extension, and as with gradual flexion starting from 60 degrees, it starts getting taut, and similarly the vice versa happens in the with the PL ligament, where it is lax in flexion and gets taut in extensions and rotations of the knee in extensions. So as you can see, in an extended knee, the fibers come to lie parallel to each other, but with progressive knee flexion, the attachment of the posterolateral bundle moves forwardly, and there's crossing over of bundles with the knee flexion. So since the AM bundle gets taut only after 60 degrees of flexion, its primary action is to prevent anterior translation flexion, and the primary function of posterolateral bundle is to prevent rotational force, rotational strains in extension. So there has been a lot of debate on regarding whether there is a necessity to reconstruct double bundles in ACL reconstructions. So example, looking at this study by O'Driscoll, published in 2012 in Journal of Arthroscopy, where they compared, they had a similar tibial entry point, and they compared the outcomes using different femoral entry points. femoral tunnel positions. This was done with using 6 cadaveric models, and BTP graph was used. So all the graphs after reconstruction were subject to a lot of anterior translation forces and rotational forces. So these are the 2 different femoral tunnel positions they used. So the red marks the center of the anteromedial bundle, whereas the yellow point marks the center of the ACL between the anteromedial as well as the posterolateral bundle. With respect to their study, they say that a single bundle reconstruction around the center of the ACL, that is between the anteromedial and the posterolateral bundle, was sufficient to address both anterior translation as well as rotational stabilities in the knee. So they advocate a single bundle reconstruction in the center position of femoral tunnel. So coming to the arthroscopic landmarks, which can be used to identify the footprints. So the most, with respect to femur, the most commonly used landmarks are the bony landmarks that can be used are the lateral intercondylar ridge and the lateral bifurcate ridge. So of these 2, the lateral intercondylar ridge or the residence ridge, the most easily identifiable and the most reliable landmark for identifying the femoral footprint. The lateral bifurcate ridge is very subtle and difficult to identify, and can also be easily distorted while using shavers or curettes to clear the footprint. And it appears as a small ledge rather than a definite notch as like the LIR. And if looked for, can be palpated with the probe. And but it is an important crucial landmark for in double bundle tunnels to locate the anteromedial bundle and the posterolateral bundles. So other landmarks that can be used include the distal and posterior articular cartilage margins and also proximal point of the femur. So this is a diagram depicting the orientation of the bundles with respect to the landmarks described. As you can see, there is the lateral intercondylar ridge and the bifurcate ridge, so dividing the attachment to the anteromedial bundle and the posterolateral bundle. And there's a posterior point corresponding to the posterior articular surface of femur, and there's a distal point corresponding to distalmost articular surface of femur, and the proximal point corresponding to the proximal articular cartilage extension of the femur. So this was a study published by Ziegler et al. In the American Journal of Sports Medicine in 2010. This was a cadaveric study where they tried to like measure and put forward the approximate distances from the of ACL center, the anteromedial bundle center, and the posterolateral centers from the commonly used landmarks. So as you can see, with respect to the lateral intercondylar ridge, the ACL center is about 6.4 mm posterior to the lateral intercondylar ridge. When comparing the AM center, it is nearly much more posterior at 7.1 mm. And the PL center is much more closer to the ridge at just 3.6 mm from the intercondylar ridge. Similarly, with respect to the bifurcate ridge, the ACL center is 1.7 mm proximal to the bifurcate ridge. The AM center naturally is much higher than and much more proximal, while the PL center is much distal to the bifurcate ridge. Similarly, they described with the other possible landmarks. So, but most commonly use a lateral intercondylar ridge and the bifurcate ridge. So, with respect to this, you can see this is a sagittal cut of femur at the intercondylar arch, showing the ACL with the intact ligaments. So you can see there's this corresponds to the lateral intercondylar ridge, and the perpendicular line the line in between is the bifurcate ridge, dividing into an anteromedial insertion and posterolateral bundle insertion. So with this landmarks as for Ziegler, this is roughly where the centers of the anteromedial bundle would be, and this will be for center of the ACL between the centers of anteromedial and the posterolateral bundle, and this point corresponds to center of the posterolateral bundle. So this is again a CT depicting the same. So the blue point corresponds to the anteromedial bundle insertion, and the green point corresponds to a posterolateral bundle insertion. So another point to be noted is that just as discussed in the functional anatomy, there is the fibers come to life parallel when the knee is in full extension, and with progressive knee flexion, the position of the fibers changes. So as you can see, with the 60-degree flexion, the posterolateral bundle comes to lie shallower compared to the anteromedial bundle, And with the 120 degree flexure, it comes to lie shallower and superiorly with in comparison to the anteromedial bundle. So this should be the key determining factor and key modifier factor for identifying the bundles rather than trying to manipulate the scope to locate the bundles. So coming to the arthroscopy landmarks within the tibia, the most commonly used landmarks, body landmarks include the, which can be used include the lateral and medial eminences. And there's a anterolateral fossa, which is just the medial to the articular surface of the tibia. And there's also an ACL ridge, which is it denotes the anteriormost extension of the ACL insertion. There's a point called the ACL tubercle, which is just the lateralmost point of the ACL ridge just before the anterolateral fossa. And of course, there's the retroeminence ridge, which corresponds to the anterosuperior attachment of the PCL. So the other soft tissue landmarks can be used with respect to tibia include the anterior horn of the lateral meniscus and the anterior intermeniscal ligament. So the anterior horn of the lateral meniscus is in close proximity to the posterolateral bundle as well as the anteromedial bundle, with the small fibers going to the from both the AM bundle and the PL bundle to the anterior horn of the lateral meniscus. So this is another picture summarizing the attachment of the ligaments with respect to the landmarks described before. So you can see the anteromedial and the lateral bundle just behind the ACL ridge and just medial to the attachment of an anterior horn of the lateral meniscus. And of course, in the femur, there is the lateral intercondylar ridge and the bifurcated ridge, delineating the attachment of the anteromedial bundle as well as the posterolateral bundle. So as we know, the tibial attachment is a oblique orientation has a comma-shaped insertion with oblique division between the anteromedial and the posterolateral bundle. So the most commonly used landmarks and the reference for ACL center from these landmarks is that from the ACL ridge, the ACL center is 10.5 mm posterior, 13 mm anterior to the retroeminence ridge, and 7.5 mm medial to the anterior horn of the lateral meniscus. In the same study by Ziegler et al., they have described the location of the AM bundle and the PL bundle centers with respect to the above mentioned landmarks. So as we can see, the AM bundles from the ACL ridge is much closer to it, and PL center is much more posterior to it. And from the retroeminence ridge, naturally the PL bundle is much closer to it, and the intermedial bundle is much anterior to it. And similarly, from the anterior horn, the AM bundle is a little more medial compared to the ACL center, and the posterolateral, the PL bundle is a little more lateral compared to the PL center, and it is taken from the posteromedial aspect of the anterior horn of the lateral meniscus. So this is a diagram depicting the same, where we can see the green point denotes the location of the posterolateral bundle, center of posterolateral bundle, and the blue point denotes the location of anteromedial bundle. So the natural ACL is the center of the ACL would be between these 2 points at around this level. With respect to anterior intermeniscal ligament, there is a study published showing that the anterior intermeniscal ligament corresponds to the ACL ridge in the sagittal plane. The reference from ACL ridge can be used with respect to AAL as well, meaning the ACL center is located about 9 mm posterior to the anterior intermeniscal ligament. Yeah. So traditionally, the most commonly used reference point was the PCL. The practice was that the ACL footprint was taken 7 mm anterior to the PCL footprint, PCL ligament. So what are the drawbacks of this technique is that it cannot be used in knees with an injured PCL. In addition to that, in knees where there is a lax or non-functional PCL, there can be subluxations of the tibia. So taking a reference of 7 mm from the PCL in such cases would not be anatomical. And also studies have found that the position based on PCL tunnels are found to be much more posterior to the anatomical center of the ACL. So thus the more reliable landmarks for anatomic footprints of the tibia would be the anterior root of the lateral meniscus and the retroeminence ridge. Just a few points about positioning and channel creation for the femur. So it is advisable to keep the knee at a 90 degree rather than hyperflexion for initial choosing of the entry tunnel position, since this gives better control and better visualization in locating the landmarks as well as making the initial entry point. And hyperflexion is recommended during tunnel creation with the reamer, to the advantage being that it prevents posterior blowout and also it increases the length of the tunnel gain within the femur. So there's no substitute to the native remnants of native ACL as the reliable anatomical landmark. However, it don't be always the case in cases where there are in chronic and revision cases where the remnants are not available. The most reliable landmark that can be used for the femur would be the lateral intercondylar ridge, and for the tibia would be a point medial to the midpoint of the anterior horn of the lateral meniscus. So just a few words about the ribbon concept. So this was based on the cadaveric study by Robert Smigelski, published in the Journal of Knee Surgery and Sports Traumatology in 2015. And they further followed up this proposed anatomy and done ACL reconstruction based on this, and published in JBJS in 2016 by the same authors. So what they mean to by the say the ribbon concept is that the femoral attachment, as discussed, the crescent shape with the anterior border with this the corresponds to the lateral intercondylar ridge, the residence ridge, and they say it is more likely continuation of the posterior femoral cortex, and the posterior border of the attachment is the limit of posterior cartilage or lateral femoral condyle. So this is what they mean to say, where in a cadaveric specimen of the intact ACL on knee flexion, they found a flat ribbon-like ACL. So, and also this is the sagittal cut showing the attachment and the orientation of the lateral intercondylar ridge with respect to the posterior femoral cortex. So with respect to the femoral insertion, they're describing two types of insertion. One is a direct insertion with a transitional zone and zonal architecture with a double tight mark as in layered insertions. And this fibers insert at right angles to the bone. So they advocate that this is the only real footprint concerned with a real footprint of the ACL. And the rest of the attachments is without a transition zone, represent just fanning out of the fibers. So if we can look at the picture here, this is a sagittal cut of the femur at the level of intercondylar notch with the ACL stripped off from the tibial attachment. So the fibers along the yellow line seem to attach into the anterior border of the lateral intercondylar ridge. It seems to be in line with the posterior femoral cortex. And these fibers also seem to be attached at 90 degrees to the bony attachment. However, rest of the insertions in the posterior part of the femoral condyle look like mere fanning out of the fibers and attached to the rest of the crescent shape area. So what is the clinical relevance of this description is that they advocated tunnel placement only at the direct attachment rather than the center of the direct and the indirect attachment. Meaning they advocate a notch, femoral tunnel placed very proximal and anterior in the notch. And with respect to the double bundle concept, this would be within the substance of the anteromedial bundle rather than in the center of the anteromedial bundle and the posterolateral bundle. They say that this is a more anatomical tunnel rather than center of the AM bundle and the TL bundle. This ribbon concept has been in study, and there have been few studies as early as 1995 and 1993 by Ondensten and Arnowski. Both were cadaveric studies. So from their cadaveric study also, they quoted that they couldn't make any distinction in the ACLs. They dissected as an anteromedial and posterolateral bundle. They say that the bundles may be just functional rather than anatomical, meaning depending on the orientation of the fibers and different degrees of deflection, some parts of the ACL just twist on itself to look like a posterolateral bundle and the anteromedial bundle. And this twist got unwound on extension. And the implication of that is that since the ACL reconstruction done with the knee flex position, they are advocating twisting of the graft introp, so that and they are suggesting that might be more beneficial than placing the graft as such. So coming at the tibial insertion, this is the models described in this study, cadaveric models. So as seen here, there is a tibial attachment. It's a comma-shaped tibial attachment, and there is only the attachment of the lateral meniscus. After proper dissection of all the surrounding soft tissue, they say there is only one bundle of insertion of the ACL, and there's no posterolateral bundle. And this is a model depicting the supposed areas anteromedial and posterolateral centers. As seen in this cadaveric model, there's only attachments corresponding to the anteromedial bundle, and the posterolateral bundle area corresponds to the just attachment of the anterior horn of the lateral, just point medial to the anterior horn of the lateral meniscus, and there are no ACL fibers. And they further describe the three types as based on the orientation as C shape, J shape, and a C small C shape. So what is the relevance of this description to ACL reconstruction is that the most isometric point for femoral insertion is proximal and high anterior within along the intercondylar ridge, corresponding to the area of direct fiber insertion of the ACL. And as per the study, such a eccentrically placed graft is no less anatomical and probably much more physiological in comparison to normal native ACL. They also backed their findings with the findings published, where they followed up nearly 200 cases of isolated ACL reconstructions, with all of them being in professional football players. So they compare the rates between central anatomical, as in between AM and AL bundle, and anteromedial portion, that is high and anterior along the intercondylar ridge. And they found the retear rates to be much less in the high and anterior portion compared to the central anatomical portion. So take home message, ACLs consist of two bundles, the anteromedial and the posterolateral bundle. AM primarily for resisting anterior translation, PL for aids and rotational stability. Intraoperatively, varying the knee flexion is crucial, is the easier and easily modifiable factor for identifying location of the bundles. And current understanding of the bundle concept is still under debate. They're suggesting that bundle concept may be functional rather than an anatomical distinction as an AM and a PL bundle. No substitute for natural ACL as a landmark. However, in cases where the ACL is not intact, most reliable landmark in the femoral side would be the lateral intercondylar ridge, and the most reliable landmark for tibial tunnel would be point medial to the anterior horn of the lateral meniscus. And the most isometric point for femoral insertion is probably high and anterior and the lateral intercondylar ridge rather than the center of the AM and the PL bundles. Thank you.
Praveen, a good literature review with good, relevant, comprehensive talk. Few things of, so you told 6,000 BC, 3,000 BC, right?
Yes, sir. Yes, sir.
How come 3,000 BC? What was the information?
Some even Roman literature and some Egyptian scrolls, they have description of some ligament within the knees.
Okay. Okay, just interested to know. Rest of the things you have covered everything comprehensive, right from nerves to vessels, and the current concept. The thing which we were discussing with Geethan in the last conference, which was in Chennai, was the tunnel, exactly as the last slide. Most of them, the last paper, the most of them are still doing the central anatomical position, slightly low. We were discussing and wondering whether that is right or more of anteromedial is right. What is this paper actually? When was this paper? This is Mikulski's paper.
Yes, sir. 2016
paper. Okay.
sir. But I actually came across few studies like in the later part, like 2019, 2020. Some studies are advocating a center position between AM bundle and PL bundle as more anatomical. So, I mean, those are also very relevant in index papers, sir. So
yeah, that's a
really
controversial point currently. There's a concept called ANOVA.
Okay, sir.
Or something called as where initially the evolution was from.
Sir, మీరు మీటింగ్ వస్తున్నారు కదా?
Dr. Vidyasagar, you have to mute your mic.
మీ ల్యాప్టాప్ కావాలి సార్.
Dr. Vidyasagar.
అది కనెక్షన్ ఉంటది కదా అది.
Can somebody call Dr. Vidyasagar? Dr. Hitesh,
ఎందుకంటే నేను చేసింది లిబ్రే ఆఫీస్ లో.
Yes, sir. Hello, sir.
yeah, he's muted his mic. Okay. So the position of the tunnel was initially it was only central. Then they said to come down slightly. Then they moved up slightly. And
Yes, sir.
currently it's not very clear whether pure AM is better or pure central is better. But we are slightly higher than the rest of the people currently. Whatever I saw, people in surgeons in Chennai are more of central. We are slightly higher towards the intermediate. We have to see the results. Retear rates, we are not able to quantify them. Only
Yes,
thing
sir.
very currently which we are doing is in PTBs we find that excursion is there in some situations, which indicates it's not isometric.
Okay.
When we flex and extend, there is movement of the graft in certain types of tunnels, which is high. So that is a concern whether we are going too high. So we have to keep seeing the literature and evolve as per the recommendations, but literature also mixed. More
Yeah.
recent ones say more central, right?
Yes, sir. I mean, there are studies for supporting both, sir.
Yeah. So it's still not very clear. There are so many things in ACL which is not very clear.
So,
So you brought
credibility
up
of
all
this.
the.
Yes, sir. This paper they are done exclusive and high demand professional football players, sir, and I also have a good long term follow up with 12 years with a minimum of 2 years follow up. So,
They've quoted the retear rates, but how about return to sport and return to the same activity level?
I will look. I don't think it was mentioned, so I'll look into it, sir.
That is more important. So
Sir, one more policy could be they would start on the starting position, like the exact guide wire can be predicted, but once the drill is done, it must be overlapping. No, like you can't predict the exact location of the drill.
no, even the final tunnel position you can measure. We can take grid methods. You can measure. Yeah, obviously the tunnel. When you see the tunnel itself, you can notice it. It will be high or low.
Okay.
So sometimes if the graft is not really functional and the person is not returning to the same level of activity, obviously it won't retear. So that aspect is also there. So whether they are able to return should also be studied.
Yes, sir.
And sir, what about the twisting the graft?
Sorry, they were not audible.
So there was a paper he mentioned about twisting the graft before fixing it.
Yeah. No, Smigelski's concept, or here Mukesh Ladda in India also does that. You make a rectangular slot rather than a round slot. You keep the bone plug and distally you rotate the bone plug in orientation with the AM and PL.
Okay.
This is with bone plugs. Is that right, Praveen? Not with the
Yeah.
hamstrings.
They use both
Hamstrings also.
hamstrings as well as the. Yes.
Yeah, hamstrings. It's only in a double bundle you can do that. The single bundle, it's not practical to do that. It'll anywhere rotate unless you're putting a screw.
Okay, sir.
What Mukesh Ladda does is PTB or hamstring?
PTB, sir. PTB with the.
Yeah.
He actually is given us PPT to show it to you, so that he's planning to market that slotted jig, which he uses. It's just like a punch where it is. It makes a rectangular slot. You drill the tunnel, smaller size, and enlarge it using that instrument into a rectangular slot, and both sides, femur and tibia, and take
They've been published earlier, isn't it? There are a lot of some publications. I remember we having a debate on that also.
Yeah, Smigelski does that, but his has some modification, and that instrument is something which he has done, which can be used. he wants to send it here and wants us to try as a multicentric thing. But the size will be slightly larger, but the tunnel will not cross the resistance ridge. It will remain, majority of that rectangular slot will remain posterior to the resistance ridge. So that his claim is that you do not come in front, so it's always anatomical and more of ribbon aspect, I mean concept type of reconstruction.
Okay, sir.
And SRMC is still doing
Transtibial.
transtibial?
Now sir is Armangam sir is doing it with the flexible reamer, sir.
Oh.
He demonstrate live. So he does that the same transtibial with the flexible femoral reamer. Their tunnels are slightly, femoral tunnel also slightly low, but he still managed to do a low tunnel transtibial, probably because of flexible reamer.
Transtibial, if you're not very particular, as the talk cabin, it is high and anterior eventually.
Yes, sir.
Any other questions in anatomy? Any doubts to be cleared? Good, Praveen. So nothing more.
Thank you,
We'll
sir.
go on to next.
Thank you, sir.
Good morning, everyone. So I'm audible, sir. My slide is visible, sir.
Yeah, Santosh, please go on.
Yeah. Today I'm going to talk about biomechanics of anterior cruciate ligament. Wait. So biomechanics is one of a major key to the function, stability, and aging process of the knee joint. So knee joint is a major complex.
Santosh.
Yeah. What happened? Sorry.
Go on, Santosh.
Yeah. The knee joint is a major and complex joint, and its stability and motions are basically controlled by the ligaments around the joint, mainly ACL, PCL, medial collateral, lateral collateral, and ligaments. So, high rate of injury in athletes and active individual or causes the most common injury will be on the anterior cruciate ligament. ACL anterior cruciate ligament has its origin at medial area of lateral femoral condyle and inserts in tibia with tibial plateau near to the anterior of lateral meniscus. So there are two bundles, anteromedial and posterior bundle, which was explained by Dr. Praveen. They act together to give ACL is a unique biomechanical properties, and ACL function as primary restraint against the anterior translation or anterior shear on tibia on the femur. This is important to prevent hyperextension and providing overall stability to the knee during locomotion. To a lesser extent, ACL provides a resistance to internal and external rotation. So the role of AM bundle and PM bundle depends upon the knee flexion angle. With knee in full extension, the posterolateral bundle is taut. As the knee flexion increases, PM bundle loosens and AM bundle becomes tight. This shift in tension between the bundle also allows some portion of ACL to remain tight at all times. So in this picture, it depicts that the blue line is sag in extension and posterolateral bundle is taught in extension. The second one is blue line is taught in flexion, high degree of flexion, and red is sag in the posterolateral. So in intact ACL, the force producing an anti-translation of tibia will result in maximum extrusion of tibia at about 30 degree of flexion with neither of ACL bundle or particularly tense. So this is the in this diagram the big hyper extension minus 10 degrees hyper extension where PM bundle is so strained of ACL is so strained and it gets descended when it becomes sag or loose at 120 degree of flexion. Both the bundles are loose or sag at 30 degree of flexion. So if the PM bundle is taut, so no anti-translation of tibia is possible in full extension. So ACL acts as a second resistance against either varus or valgus at knee. With valgus loading, the length of both of the bands of ACL increases as the knee flexion increases. In case MCL injury is there, the valgus movement will increase with a strain on the ACL throughout the flexion range. And the medial rotation of tibia on the femur increases a strain on and anteromedial bundle of ACL, with peak strain occurs between 10 degree and 15 degree. A study done by Gabriel et al. In 2004, published in Journal of Orthopedics, he tested an anterior tibial load and a combined rotatory load applied to the medial side of the knee, stressing the valgus angle and the internal tibial torque to test the allocation of force between the PM bundle, posterolateral bundle and AM bundle using a robotic testing system in a 10 cadaveric knee. The greatest force transmitted through the AM bundle were at 60 degree and 90 degree of flexion. The force was greatest for the PM bundle at full extension. The force, the greater the flexion angle, the PM bundle had significant higher in situ force than the posterolateral bundle. And another study by Sakin M and Fox, it was published in 1977, using a cadaveric study. The knee found that posterolateral bundle handled more force overall than the anteromedial bundle in response to the anterior tibial load. This suggests that whereas the in situ force in a AM bundle remained relatively constant and unaffected by the change of flexion angle and tibial load force. This suggests that reconstruction during surgery of PL bundle as close possible to that intact knee might be more important than the AM bundle, because most of the injury of ACL occurs when the knee is in a full extension, and the PM bundle is considered more important for overall biomechanical stability of the knee because the in situ force is greatest in the PM bundle at full extension. And now coming to muscles surrounding the knee joint are capable of either inducing and minimizing the strain in the ACL. And a study by Marishwar M and Jain, biomechanics of knee anterior and material reconstruction, was done in 2018. So these are the muscles and joint reaction force around the knee joint. In tibiofemoral joint near full extension, quadriceps muscle contraction is capable to generate an anterior shear force on tibia, thereby increasing the stress on ACL. Where Fleming et al. Had reported that gastrocnemius muscle is similarly has the potential to translate a tibia anterior and strain the ACL by how means the proximal tendon of gastrocnemius wraps around the proximal tibia and effectively push the tibia forward when the muscle becomes tense through active contraction or passive stretch. The hamstrings are capable of inducing posterior shear force on tibia throughout the range of flexion, which leads to greater knee flexion angle. And the hamstrings have the potential to relieve the strain on the ACL from anterior tibial translation. With the foot on the ground, soleus has the capability or ability to posterior translate the tibia and assist the ACL in restraining anterior tibial translation. When the quadriceps contracts eccentrically during knee flexion and concentrically during knee extension. On the other hand, hamstring muscle perform an inversive action. These two muscles, hamstring and quadriceps, are antagonists. So now the shear force due to patellar tendon, that is I quadricep force, are the largest share in determining the total shear force and occurs during the contralateral toe off. While walking, the ground reaction force occurs in addition to the above listed force, and the ground reaction force always applies a posterior shear force as a line of action of the resultant force passed behind the knee. So now we are in this picture that we are talking about total shear force at the knee joint shall depends upon the magnitude and direction of the individual muscles. So maximum shear force, it significantly depends on the force exerted by the quadriceps muscle via the patellar tendon. Both anterior and the posterior shear force, translate the femur over the tibia in respective direction. These result movements are restrained by the ACL. Now coming to the level of walking and stair climbing in knee flexion extension. So flexion and extension of knee includes both rotation of tibia with respect to the femur and translation of femur over the tibia, that forward and back. The level of walking involves up to 30 degrees of flexion at knee, and in case of stair climbing, the knee flexion angle varies from 60 to 135 degree depending upon the height of each chase. Now coming to center of rotation, the center of rotation varies with respect to the angle of knee flexion. At 30 degree, first 30 degree of flexion, the femoral condyle undergoes minimal anterior translation. Between 30 to 135 degree of femoral degree, the femoral condyle undergo larger anterior translation. So this, from this picture, the depicts the illustration changes in the center of rotation of femur over the tibia, that from 1 to 10 degree of position. In B, attributes to the anatomical position during the knee during the rotation of femur over the tibia. Now another study by Bezier et al. External loading of knee during running and cutting maneuver. It was published in 2011. He told that compared with running, there is a significant increase in ACL load during the side stepping and cross-cutting maneuver. This results of larger increase in valgus or varus and external intervention movements. The increased stress during cutting put the ACL at risk, especially when knee is at flexion angle between 0 and 40 degree. Morrison was the first researcher to calculate the force acting on the ACL through stimulation. In his study, the EU 9 males and 3 females were made to walk on the force plate and simultaneously emerge from both front and the sides. The acceleration on each segment of the lower limb was calculated from each frame by imaging of the gait. So the ground reaction force and the acceleration from the force plate and from the image provide the total force acting on the knee. The maximum force acting on ACL was calculated to be 156 Newton. And the ACL was loaded during 5% to 25% on a gauge cycle after the heel strike. The corresponding knee angle varies between 15 degree to 120 degree. And another study published by Collins, a sagittal plane model was used to estimate the force acting on ACL during a gait cycle. The effect of antagonist and synergetic muscle were included in the dynamic analysis of level of walking. About 900 Newton force was estimated to act on the ACL during early stance phase. Shell, Bruni et al. Calculated and explained the pattern of loading on ACL on the gait cycle of normal walking. He predicted that ACL forces, which shown in the figure, as function of gait cycle as well as the knee angle. In this study, he reported the maximum load of ACL occurs during the mid-stance phase. This corresponds to the knee angle of 15 to 20 degree. And during the swing phase, the ACL has minimal load. Sex-based difference in biomechanical property. Females are reported to suffer 2 to 7 times fold in ACL injury than males of counterpart of the same age. Excessive load on ACL per unit body weight are expected in females due to the lesser stiffness of the knee muscles. The cross-sectional area, length, and volume of ACL are smaller in females than males. Ashmi et al. Has reported that ACL of a female has lower fibril concentration and percentage area occupied by collagen fibers than the ACL of male. Yvette et al. In both male and female studied both male and female young adults were assessed for a decade using a coupled mechanical epidemiological approach. The study found that female player had 4 neuromuscular imbalance: ligament dominance, quadriceps dominance, leg dominance, and trunk dominance. So ligament dominance means in the landing type of action, the knees of female player tend to go valgus position. So the posterior kinetic chain, the gluteus maximus and medius, the hamstring, gastrocnemius, and soleus do not observe a sufficient ground reaction force. So the force of ground reaction is caused to the ligaments. Quadriceps dominance. Infusing quadriceps to define the knee stability, the knee and the stability without involvement of posterior muscle chain, which leads to generation of anterior shear force at the knee. So the ACL serves to check anterior and posterior translation, induce a determinal effect due to anterior shear force. Then leg dominance is one leg dominance in a female that results in greater asymmetry between the lower limbs and had a greater risk of future injury. And trunk dominance, imbalance relates to instability, precise control the trunk in 3 dimensions. Female center of mass is higher off the ground in compared to the male center of mass. So in addition, without the muscle for control, the amplifies the imbalance, leading to higher lateral movement during sports activity. Now, rotational instability, the role of medial and lateral ACL fibers might be versatile. So in intact knee, the fibers resist a complex internal tibial intertibial rotation force. Study done by Amis et al. For biomechanical rotation stability and anatomical anticruciate ligament in 2005. Although the resulting force of on an isolated internal rotational stability seems small, so the rotational axis of the knee alters from the center to the medial position near the pars intermedia of the internal meniscus, that is medial meniscus, when the ACL is ruptured. As a consequence, there will be larger momentum at the lateral compartment, increase in momentum at the lateral compartment. Kanamori et al. Had published an article of in situ force in medial and lateral structures of intact and ACL deficiency in Journal of Orthopedics in 2000. So he determined both medial and lateral collateral ligament compensate for the in situ force against the internal rotation when the ACL is ruptured. Based on the effect, medialized central of rotation with subsequent increase of motion radius on the lateral compartment after the ACL is ruptured. The in situ force of posterolateral ligament structure increases up to 413% at 15 degree of knee flexion. It can be assessed by pivot shifting test. So from this picture, the right side this is the position of this safety, that is back should be at normal lordosis and hip is flex, neutral abduction, neutral abduction, adduction and neutral rotation. Knee is flexed, tibia is in neutral, both the feet in controlled balance. So the second piece depicts the point of no return, that is body motion will be forward flexed and rotated opposite side, and it hip in adduction and internal rotation, knee is less flexed and valgus, and extra tibia is in internal or external rotation, and one foot out of control and imbalance. So this, regardless of rotation effect on the ACL loading pattern, ACL injury occurs when the knee is slightly flexed and tibia is rotated in either direction in weight bearing. So flexion and medial rotation, the ACL tends as it winds around the PCL, whereas in flexion and external rotation, ACL tends to stretch over the lateral femoral condyle. Now, joint pressures. Gardner published an article of Journal of Orthopedics in 2012. Several biomechanical and in vivo studies have found that decreased total joint pressure after ACL rupture by pressure sensitive sensors or electromyogram driven models. Consequence of decreased joint pressure, the knee flexion movement after ACL rupture is also decreased. Lee G, Moses JM, they published an article of ACL deficient alerts the in vivo motion of tibiofemoral cartilage contact in both anteroposterior and medial lateral direction in JPGS in 2006. So they, in this study determines tibiofemoral contact points during a one leg lunge at different knee flexion angle in vivo study. They found that there was a significant shift of contact points on the tibial surface after ACL rupture, most on the knee at knee flexion angle of 15 degree. In medial compartment, the contact alters to be more posterior and more lateral position towards the intercondyle hemisphere. In lateral compartment, the lateralization of contact point was also observed, but without alteration in the anteroposterior axis. In this picture, the blue points which tell that lateral shift of femoral tibial contact point at various knee flexion angle with ACL in intact, with the ACL is intact, this blue points, whereas the red point depicts that if ACL is ruptured, the force on the tibia at various degree of angle is mostly in the posterior aspect, in the lateral compartment, and in the medial compartment is in the medial aspect. So this green and purple depicts the increased contact stress after ACL rupture in the posterolateral compartment during pivot shifting is measured in green area, and in the posterior compartment, posterior in the medial compartment, posterior aspect in the medial compartment is mentioned in the purple area during Latchman testing. This is during Latchman testing in the posterior compartment. This is during pivot shifting in the lateral compartment. Tajima ji et al. They have done a study on their study in this study. They told that while total patellofemoral joint pressure and the pressure of medial patellofemoral compartment decreases after the ACL rupture, whereas the lateral patellofemoral joint pressure increases with higher angle about 60 degree. So conclusion that knee joint is a complex with shifting contact points and pressures on the axis that are affected when the ligaments are get injured. The ACL as an intra-articular ligament has strong influence of the kinetics. So often other meniscal ligamentous injury accompanying ACL rupture and further deteriorating the resulting kinematics and clinical outcome. We have to know about, so take home message is the force acting on ACL, kinematics of knee joint in level of walking and stairs, center of rotation angle, then sex-based difference in biomechanics and rotational instability and joint pressures. Thank you.
Santosh, your content was good, but the way of presentation must improve. Have you understood what you presented, Santosh?
I hope, sir.
You're not reading from your notes, right?
No, sir, I'm not reading, sir.
So you should present in a way that you give out whatever you understood. So, for example, what are the neuromuscular biomechanics in imbalance Can you mention what are the biomechanical mechanisms in a
So
female athlete?
the dominance, sir.
Ah,
The leg mainly female there's in 60 ligament dominance is mainly in landing type of action. The in posterior kinetic chain, the gluteus maximus, medius muscles, hamstring muscles, soleus, they don't observe a sufficient ground reaction force. So the they leads they made the force on the joint and ligaments have higher amount of force because of short duration of the ground reaction force occurring over the knee joint, which leads to the ligament injuries, sir.
no, you mentioned about 4 dominance, right? Ligament
Yes.
dominance, muscle
Yes, sir.
dominance,
Yes,
leg
sir.
dominance, and trunk dominance. What do you understand from that?
So
No, you mentioned, I know what you mentioned, but what did you understand from that is my question. Did you understand whatever you talk is the concern? You mentioned whatever is required, good,
yes, sir.
but have you understood whatever you presented? So for example, in the steps, go to the slide of steps, stair climbing. So what did you understand from that? So what did you understand from this meaning of the, let's go to the previous slide. The opposite, you were mentioning about the opposite toe off. So what is the meaning of that? Previous. No, toe off. Next one. Next.
So from this one, sir.
Hmm.
So opposite. So when the when the force ground reaction when we more total shear force on the when patellar tendon has greater shear force on the affector side. What you say?
So what is the meaning of the CTO? The last point.
While walking, the opposite when opposite leg with contralateral toe of time, there will be more force acting on the patellar tendon and quadriceps muscles, sir.
Where? So the highest force is when the in one knee, when the opposite leg toe of face. That's what you're giving in the diagram, the next slide.
Yes, sir.
That indicates the opposite side actually.
Opposite.
The opposite side toe off. That's what it means from that statement. Is it true or
Yes.
not? I'm not sure.
Yes, sir. The opposite toe of so the ground reaction flows always posterior.
Is it the same side or opposite side? I'm not sure.
It's the opposite side, sir. Opposite side, sir. Opposite side, sir.
Okay, I'm going to look. You send me this article. Let me look into it and.
Okay, sir.
Okay, I'm not sure how come opposite toe off as maximum. I'm not sure. So you've given the content, but whatever you present, you must understand and present.
Okay.
Your understanding must improve, and the way of your presentation also must improve. You need to rehearse and practice multiple times.
Okay, sir.
Otherwise, you covered the content, but the presentation must be better.
Okay, sir.
So you won't add any points. Any doubts from fellows regarding biomechanics?
No, to Santosh Raj, just what he said. Santosh, what you must do is you must give a talk, record it, and play it back. Then you will keep improving.
Okay, sir.
Okay.
Okay.
Good. I mean, you've done some hard work. Good. Thank you.
Thank you.
Thank you, Santosh. You can unshare your slides. Shall go on to the next topic. Plastic.
You can share.
Share
Share screen. Desktop share.
three. No, I have 2 cases, 3 cases. Now what cases? PPT only.
One second. You are not muted, guys. Wait. Allow this. Do it. No, oh, sure. Is it happening? Yeah. Sharing has started. There's a PPT. Keynote. Why is it not opening? Is it already open?
Close, sir. No, it's not actually open.
Open a PPT.
I just want to click.
Good.
Good morning, sir. Am I audible?
Yeah, you are audible.
Good morning, sir. Am I audible? Good morning, sir.
You are audible.
Yeah, good morning, sir. Today I'll be presenting a topic on spondylolisthesis. Spondylolisthesis is defined as the anterior slipping of one vertebra on the next lower segment. So, spondylolisthesis always define the slipping over the caudal vertebra. It mainly spondylolisthesis is due to failure of anatomic structures that normally resist the anterior directed forces, which are mainly the contraction of erector spinae muscle and the force of gravity. Posterior structures mainly involving facets, annulus fibrosis, posterior bony arch, and pedicles. The vertebrae are aligned in a way of hook and catch concept. The hooks is mainly formed by the pedicles, pars interarticularis, inferior process of the cephalad vertebra, and the catch is mainly formed by the superior process of the caudal vertebra. Coming to classification of spondylolisthesis, there are many classifications of spondylolisthesis, which the earliest, most used classification is mainly given by Wilsey, Newman, and McNabbs. He classified the spondylolisthesis into mainly 5 types. Dysplastic type, which involves the dysplasia of the posterior elements. Isthmic type, where there is a defect in the pars interarticularis. Degenerative listhesis, traumatic spondylolisthesis, and pathological listhesis. Pathological spondylolisthesis mainly involved a defect in the bony architecture, such as osteogenesis imperfecta or osteopetrosis. Recently, few other scientists added iatrogenic also post any spinal surgery. They classified iatrogenic spondylolisthesis. Marchetti and Bartolozzi classified the spondylolisthesis based on the pathogenesis and etiology also. So they mainly classified the spondylolisthesis into developmental and acquired. Developmental meaning the spondylolisthesis occurs from the birth to the developmental period, that's the growing phase of adolescence and adulthood. Whereas acquired, it is usually acquired at some point of time in their adulthood. So developmental involved high dysplastic or low dysplastic, both entities with lysis or with elongation of the pars. And again, in acquired spondylolisthesis, classification spondylolisthesis was classified as traumatic, which include acute fracture or stress fracture. Post-surgery, which involved the direct surgery or indirect surgery. So direct surgery involving the on the spine, or indirect surgeries like laminotomy or fenestration was done. Pathologically involved the local pathology or systemic pathology, and degenerative mainly primary or secondary. Coming to dysplastic spondylolisthesis, it mainly results from dysplasia or aplasia of the posterior facet joints of the L5 S1 levels. These patients usually will be having spina bifida occulta at the level of L5, which is mainly congenital. There may be concomitant elongation of the pars intra-articularis, and it's strongly familial in nature. Coming to pathogenesis, the dysplastic pathway mainly involves when there is a weakness in the hook and catch mechanism, the load of the body is transmitted through the weaker zone. So once the weaker zones are exerted to extra forces, there will be a soft tissue restraints. Eventually, it will lead to plastic deformation. The end result will be the growth plate will be overloaded, forming at the end. There will be a abnormal anatomy of the facets or the posterior elements of the spine. Coming to this developmental dysplastic spondylolisthesis, it's mainly classified into low grade and high grade. Low grade spondylolisthesis mainly occurs in young adults. It is usually associated with spina bifida, and slip is characterized by the translation without any ambulatory or kyphotic component on the lumbar spine. High-grade spondylolisthesis usually occurs at the level of L5 and S1. It is most commonly symptomatic in adolescents. Peculiar features of high-grade spondylolisthesis mainly involves the wedge-shaped L5 vertebra, and the sacrum usually appears the dome-shaped. There will be anterior translation along with angulation at the lumbosacral region. There will be a true lumbosacral kyphosis, and these patients usually have potential to develop spondyloptosis. Coming to clinical features, the most common symptom when the patient presents is the back pain and occasionally leg pain. Usually, the patient presenting will be the age of in the adolescent age group, and usually the complaints will be aggravated by sports and other activities. Slipping occurs usually between the age of 9 to 15 years, where there is the maximal growth spurt happening. And once this phase has been crossed, the literature says there is no much slipping after the age of 20 years. Clinical signs mainly involves altered gait, protuberant on examination of the patient. There will be an altered gait, protuberant abdomen, exaggerated lordosis. Buttocks will be heart-shaped due to vertical sacrum, and on palpation of the spine, there will be a palpable step, and you may or may not be associated with scoliosis. This is a classical Fallon-Dixon sign, usually seen in high-grade spondylolisthesis, where we can see the exaggerated lumbar lordosis. There is flexed hip and flexed knee, and the patient stooped forward. He will be having the crouching gait. Now, why back pain in spondylolisthesis? Usually the cause is very unclear, and it's usually multifactorial. Few causes listed are mainly the due to disc degeneration, back pain results, facet degeneration, or due to any chronic nerve irritation from compression. Spinal stenosis also forms one of the cause for back pain in spondylolisthesis. Coming to radiological signs, here in this X-ray, there's a lumbar spine of AP lateral, where we can clearly see a break in the pars intra-articularis at the L5 vertebra in the lateral view of the X-ray. The usually break in the pars intra-articularis usually will be seen just below the pedicles level. The beheaded Scotty dog sign, which is mainly seen in the oblique view of the lumbar spine X-ray, where the transverse process forms the nose of the Scottish dog head, superior facet forms the ears, the pedicle forms the eye. The neck is mainly formed by the pars intra-articularis. Lamina and inferior facets are usually the limbs, and spinal process and the inferior facets are the limb or the hind limbs of the Scottish dog. So when there is a break in the neck, usually like in the pars intra-articularis with defect, it arounds to which looks mainly like the beheaded Scotty dog sign. Again, this is the inverted Napoleon hat sign. where usually this is seen in the AP view, and diagrammatical representation when seen from the lateral view, there will be the anterior slip and tilting of the L5 vertebra, where the pedicles will be shown anteriorly in the AP view. In these patients, lateral bending films are taken just to visualize the motion and instability at the level of spondylolisthesis. Disc degeneration and disc collapse are common at the level of spondylolisthesis because it is an attempt to stabilize the motion segment. Coming to radiological classification, Meyerding classified spondylolisthesis into 5 grades. He mainly divided the caudal vertebra into 4 different parts, and depending on the slip from 4 different parts, he classified into grade 1, grade 2, grade 3, grade 4, and grade 5. Grade 1 usually involves 1 to 25 degree of anterior translation. Grade 2 involves 25 to 50 degrees of anterior translation. Grade 3 is 50 to 75 degrees of anterior translation, and grade 4 is 75 to 80 degrees of anterior translation. Grade 5 is usually complete anterior translation of the L5 vertebra, which is mainly called as spondyloptosis. Coming to the radiological parameter, this is slip angle of Boxall. It is basically measured from the a line drawn from the posterior part of the sacrum and a perpendicular taken to it, and the second line will be the a line drawn along the inferior border of the L5 vertebra. More than 55 degrees of slip angle is considered a higher rate of progression. When there is deformation of the inferior border of the vertebra or of the L5 vertebra, superior border of the L5 vertebra can be taken for angle consideration. Coming to translation versus tilt. In the figure left side, where we can see there is a translation happening in the lumbosacral junction, but when we measure the slip angle, it hardly comes around at 10 to 5 degree, 5 to 10 degrees. But in the figure on the right side, there is a tilt happening in the L5 vertebra. This tilt, when we measure the slip angle, it usually corresponds more than 40 to 50 degrees, and this tilt causes the lumbosacral kyphosis, which alters the spine sagittal balance. Coming to various sacropelvic parameters, there are 3 basic sacropelvic parameters, mainly the pelvic incidence, the pelvic tilt, and the sacral slope. The pelvic incidence is measured from the center of the femoral head, line joining the center of femoral head to the midpoint of upper border of the sacrum, and the line a perpendicular drawn from the upper border of the sacrum. Pelvic tilt is measured from, say, from the center of the femoral head to the upper border of the midpoint of the upper border of the sacrum to the vertical axis, and sacral slope is measured as the line drawn along the upper border of the sacrum to angle made to the horizontal. Now, this mathematical formula where the pelvic incidence is equal to sacral slope plus pelvic tilt. Pelvic incidence is a morphological measurement determined by individual anatomy. It is mainly a constant entity where it is specific to the individual's anatomy. Once the pelvic incidence is made out, it doesn't change with the aging of the person, and pelvic incidence mainly tells us about the orientation of the spine with respect to the pelvis. Coming to pathomechanics, so whenever there is a spondylolisthesis translation happening, the body tries to maintain the upright posture. So it is done mainly by the lumbosacral region. So once there is a slippage of the vertebra, the body tries to hyper exaggerate the lumbar lordosis in order to keep the sagittal balance. This can be achieved, the maximum lumbar lordosis which can be achieved given in the literature is maximum of 80 degrees. Beyond that, the pelvis has to take over. So and till the maximum of 80 degrees of lumbar lordosis compensation occurs, the pelvis will be much or more or less balanced. When this lumbar lordosis reaches its threshold, the pelvis takes over the next compensatory mechanism. Then it starts to tilt, and in this situation, the balance in this situation, the pelvis usually is unbalanced, whereas it is also going for compensatory mechanisms. And in this position, there will be a tightening of hamstring muscles, and there will be a flexed hip and the flexed knee gait, which is usually seen in the Fallon-Dixon sign. Once the pelvis compensatory mechanism of the pelvis is achieved, usually the spine in order to maintain the upright posture and the sagittal balance, it will usually go for a stooped posture, so that the sagittal balance in maintaining the erect posture of the person is maintained. But once this compensatory mechanism also fails, the final stage of unbalanced spine occurs, where the patient will be having a stooped posture with all signs of pelvic tilt and flexed hip posture and flexed knee posture. And this is mainly due to an unbalanced spine and a loss of sagittal balance. Based on these things, the spinal deformity study group classified listhesis into following types. It divided into low-grade and high-grade listhesis. Low-grade listhesis mainly involved Meyerding's grade of grade 1 and grade 2, where the pelvic incidence was less than 45 degrees. It was called as a nutcracker's phenomena. And type 2, where it was pelvic incidence measured about 45 to 60 degrees, and type 3 pelvic incidence was more than 60 degrees. In high grade, again they divided into balanced pelvis and a retroverted pelvis. In the retroverted pelvis, they basically divided by the balanced spine or unbalanced spine. Usually the low grade spondylolisthesis compensatory mechanisms are enough to have an sagittal balance and upright posture. But in high grade listhesis, the compensatory mechanisms eventually fail and lead to an unbalanced spine. Coming to investigations part, lateral bending X-rays from the one of the first investigations to get through. The lumbar spine X-rays, AP view and flexion extension lateral view was a must. Lateral views reveals instability when there is 4 mm of translation or more than 10 degree of sagittal rotation greater than the adjacent level, which is identified. Coming to MRI spine, MRI is done in spondylolisthesis mainly to visualize the soft tissues and neural elements. It mainly helps to identify stress reactions on the parts before the end stage bony defect, degree of impingement of neural structures and other soft tissues, and it also defines the status of the disc. The listhesis is not usually a major component in viewing the MRI spine. Coming to conservative management, rest, initially absolute rest, followed by anti-inflammatory medications along with lumbar support. Abdominal core strengthening exercise along with hamstrings stretching is a must. 3 years follow-up showed improvement in symptoms who followed flexion exercise program rather than an extension exercise program. Coming to operative treatment, Indications for a surgical part is mainly persistence of symptoms for more than 1 year, even after the conservative management, abnormal gait or pelvic trunk deformity, development of a neurological deficit, and slip angle more than 50% are the indications. On surgery, the main surgical goals will be involving to address the past defect, to decompress the foraminal stenosis, and to address the degenerate disc disease, and to address the dynamic instability part. Coming to various operative procedures are there, which mainly involve the decompression. Decompression can be done either through a laminectomy or laminotomy plus fenestration. Laminectomy involves mainly removing of the the whole of the lamina, whereas laminotomy mainly involves removing a part of one side of the lamina along with the removal of ligamentum flavum, which is called as fenestration. Where interbody fusions, various interbody fusions are interbody fusion techniques are available. Mainly the posterolateral intertransverse fusion, which achieves mainly the posterior column stability, posterior lumbar interbody fusion, and transforaminal interbody fusion, which mainly achieves the circumferential fusion. Anterior lumbar interbody fusion achieves the anterior column stability. Oblique also the oblique lumbar interbody fusions can be achieved. Coming to case report, this is a 20-year-old male patient who was an active sports person who had low-grade dysplastic spondylolisthesis. In the X-ray, you can clearly make out there is a L5 S1 listhesis with there is a break in the pars interarticularis, and in the AP view you can clearly make out there is a defect. There is a spina bifida occulta. MRI was done. The MRI was done, and it showed not much this thing compressions of the neural elements. Here in the sagittal view, we can see that there is probably a disc bulge in the L4, L5 levels, but this is when you see it in the axial view, there won't be any disc bulge showing in the axial cuts. So this phenomena is known as pseudo disc bulge. CT of the spine was taken just to make out the pars defect and the trapezoidal shape of the L5 vertebra. Fixation was done using posterior instrumentation with minimal invasive surgery. Coming to discussion part, interbody fusion supports restores the disc height. It corrects the alignment and balance. It mainly prevents the subluxation and prolongs the instrumentation by taking the load or load sharing properties. Fusion is mainly achieved by autografts or allografts, calcium carbonate and phosphate derivatives. You are using hybrid spacers and circulage cages. Insertion of cage plus bone graft provides better stability to anterior and middle columns. Take home message: pain with instability of spine with or without neurological symptoms make the life unbearable, and patient response to conservative management is unsatisfactory. Surgery is the only option. Decompression followed by fusion and instrumentation offers potential improvement of symptoms and a better lifestyle. Thank you.
Yeah, I'm there. I've seen his presentation. Actually, he has covered quite a bit and he has understood the topic also. It's taken a little longer time, but then I thought because he has put a lot of effort, just totally can go ahead with the whole thing.
Any points to add?
Now, only thing I've seen him. seen this thing. The only point maybe like the intertransverse fusion, I think he mentioned it as gives the posterior column support. But Srishal, there is one small thing like the transverse process is actually part of vertebral body. Transverse processes are not developmentally part of the posterior elements. They are part of anterior elements. And hence a fusion in the transverse processes, if the transverse processes are very well developed and like in not in a dysplastic listhesis, in those cases sometimes anterior the transverse process may not be that developed, but in case the transverse process are very well developed and a good fusion can be achieved in the intertransverse area, we need not take it as a posterior column stability alone. That actually gives posterior column through the fusion of the facets and the column in that area, in pars, facet, all those things goes united. And as well as it fuses between the transverse processes, which are actually part of the anterior column developmentally. So that is the basis for which these posterolateral fusions were done for years together before the interbody fusion actually came into it. So it's not any inferior kind of uh, uh, grafting and fusions. So you need to modify it like it's not just a posterior column fixation. Intertransverse fusions are actually it's not 360, but it also stabilizes the anterior columns.
Okay, sir.
Dr. One point, two cases that we had of post-op OCD, knee osteochondritis dissecans cases. One I've already shown you, I think, with grade 1 listhesis with lysis. Is there any evidence that these patients have? I have two cases now who initially they didn't present. They are in follow-up for, one is 6 years follow-up, but the other is 3 years plus follow-up. They are complaining of back pain and X-ray shows grade 1 listhesis with lysis. Any, I mean, is it coexisting condition or is it incident?
We don't know. Yeah, we don't know, but we'll find out.
We can report it otherwise. If it's not there,
we'll try to do a research search. Panikalang. Panit will let you know.
Both of them are the longest follow-up we have. So probably other cases also we can follow up over time, or as a routine we can screen them for OCD. Both of them are bilateral also. Bilateral knee.
Maybe there because you know the other Dr. Yuvraj wrote a paper that he's going to present on gold medal session is again on knee and spine. Developmentally, maybe we don't know.
Yeah, we can write a case report or something descriptive study. Okay.
Okay.
Thank you very much, sir. We'll end the meeting.
Yeah, please. Right. Thank you.